Hi, my name is Peter Peñarrer, and we're going to talk about MAGE D2 and the regulation of renal cell transporters. Definition: MAGE D2 encodes melanoma-associated antigen D2 and maps to the X chromosome. We also identify two different MAGE D2 mutations in two families with idiopathic polyhydramnios. MAGE D2 affect the expression and function of the sodium chloride co-transporter NKCC2 and ACC, key transporter of cell reabsorption in the distal renal tubule, possibly through adenylate, cyclase and cyclic AMP, signaling, and cytoplasmatic head shock protein.
Disorders of sodium are actually disorders of water. That is to say, sodium is a reflection of the tonicity of the blood. So if you don't have enough stuff in the blood, or you have too much water, you'll be hypotonic and hyponatremic. Conversely, if you have too much stuff or not enough water, you're going to have hypernatremia. Let's see if we can put this into perspective by revisiting the basic sciences and going over how our body is arranged. Our body is set up something like this. The blood and the cells are separated by a semi-permeable membrane with the same amount of stuff on either side and same amount of water. All this white space, water. These circles is the stuff. We live isotonic. That is, the stuff in the blood is the same as the stuff in the cells, and the tonicity is the same. And it's that way because of the semi-permeable membrane. Now, if you had too much stuff, hypernatremia, there's more stuff in the blood than there is in the cells. And water is going to go to an area of higher concentration. So, water is going to leave the cells across that semi-permeable membrane and into the blood. The impact that this has is that the cells are going to shrink. This balances out the water, but cell shrinkage is no good. That's going to provoke some symptoms. Conversely, on the other hand, if you had hyponatremia, you had too little stuff in the blood. Now there's more water in the blood than in the cells, and because it's a semi-permeable membrane, the water is going to go into the cells. Too much water in cells leads to swelling. Swelling of cells is bad. Shrinkage of cells is bad. They both lead to symptoms. But the symptoms the person is going to feel, or that you're going to notice in a patient, is going to be dependent on calculus. What I mean by that is it's all about the delta. It's the change of sodium over the change in time. That is, how severe the sodium change is relative to how fast that change occurs, that is going to cause how bad the symptoms are going to be. So if your sodium shift is big and the amount of time it takes to get there is fast, the body is not going to have time to adjust and the symptoms are going to be worse. If the sodium shift is small and it takes a long time to get there, then the body has a chance to adjust and the symptoms may be not present at all.
Applications in medicines. Bartter syndrome is a rare genetically heterogeneous disorder characterized by renal cell wasting, hypokalemic metabolic alkalosis, and secondary hyperaldosteronism, with normal low blood pressure. Two distinct presentations of the syndrome exist: antenatal Bartter syndrome and classic Bartter syndrome. Both forms are inherited as autosomal recessive traits. Patients with antenatal Bartter syndrome may carry loss of function mutations in the genes encoding the furosemide-sensitive sodium-potassium chloride cotransporter NKCC2, the inwardly rectifying potassium channels RONK, or chloride channel beta subunit Barton.
Bartter syndrome is a rare inherited defect in the thick ascending limb of the loop of Henle. It is characterized by low potassium levels, increased blood pH, and normal to low blood pressure. There are two types of Bartter syndrome, neonatal and classic. A closely associated disorder, Gitelman syndrome, is milder than both subtypes of Bartter syndrome. Features: in 90% of cases, neonatal Bartter syndrome is seen between 24 and 30 weeks of gestation with excess amniotic fluid. After birth, the infant is seen to urinate and drink excessively. Life-threatening dehydration may result if the infant does not receive adequate fluids. About 85% of infants dispose of excess amounts of calcium in the urine and kidneys, which may lead to kidney stones. In rare occasions, the infant may progress to renal failure. Patients with classic Bartter syndrome may have symptoms in the first 2 years of life, but they are usually diagnosed at school age or later. Like infants with the neonatal subtype, patients with classic Bartter syndrome also have polyuria, polydipsia, and a tendency to dehydration, but normal or just slightly increased urinary calcium excretion without the tendency to develop kidney stones. These patients also have vomiting and growth retardation. Kidney function is also normal if the disease is treated, but occasionally patients proceed to end-stage renal failure. Barter's syndrome consists of hypokalemia, alkalosis, normal to low blood pressures, and elevated plasma renin and aldosterone. Numerous causes of this syndrome probably exist. Diagnostic pointers include high urinary potassium and chloride despite low serum values, increased plasma renin, hyperplasia of the juxtaglomerular apparatus on renal biopsy, and careful exclusion of diuretic abuse. Excess production of renal prostaglandins is often found. Magnesium wasting may also occur. Diagnosis: people suffering from Bartter syndrome present symptoms that are identical to those of patients who are on loop diuretics like furosemide. The clinical findings characteristic of Bartter syndrome are hypokalemia, metabolic alkalosis, and normal to low blood pressure. These findings may also be caused by chronic vomiting. These patients will have low urine chloride levels. Abuse of diuretic medications: the physician must screen urine for multiple diuretics before diagnosis is made. Magnesium deficiency and calcium deficiency: these patients will also have low serum and urine magnesium and calcium. Patients with Bartter syndrome may also have elevated renin and aldosterone levels. Prenatal Bartter syndrome can be associated with polyhydramnios. Pathophysiology: Bartter syndrome is caused by mutations of genes encoding proteins that transport ions across renal cells in the thick ascending limb of the nephron. Bartter and Gitelman syndromes can be divided into different subtypes based on the genes involved. Treatment: while patients should be encouraged to include liberal amounts of sodium and potassium in their diet, potassium supplements are usually required, and spironolactone is also used to reduce potassium loss. Non-steroidal anti-inflammatory drugs can be used as well, and are particularly helpful in patients with neonatal Bartter syndrome. Angiotensin-converting enzyme inhibitors can also be used. Prognosis: the limited prognostic information available suggests that early diagnosis and appropriate treatment of infants and young children with classic Bartter syndrome may improve growth and perhaps neurointellectual development. On the other hand, sustained hypokalemia and hyperinemia can cause progressive tubulointerstitial nephritis, resulting in end-stage renal disease. With early treatment of the electrolyte imbalances, the prognosis for patients with classic Bartter syndrome is good. History: the condition is named after Dr. Frederick Bartter, who, along with Dr. Pasita Prunov, first described it in 1960 and in more patients in 1962. Related conditions: Bartter and Gitelman syndromes are both characterized by hypokalemia, hypomagnesemia, normal to low blood pressure, and hypochloremic metabolic alkalosis. However,
here's the descending loop. So let's kind of get your bearings. This is the lumen of the ascending loop. So this would be the apical membrane. And then the basolateral membrane would be here. And you have your interstitial fluid in your blood off to the side of that. So once again,
Hello, YouTube, hi. YouTube user Chris recently asked us to do a video about electrolyte imbalances, so I decided today I was going to do a video about hyponatremia because it's my own personal favourite electrolyte imbalance. I appreciate that having my own favourite